Good morning and welcome to the Q&A webinar sponsored by Adam Vettel Healthcare Group. My name is Sharad Agarwal and I am the CEO of onlywebinars.com. That's what we do. We specialize in organizing webinars. This morning, I encourage all our participants in the audience to use the chat feature to send in your questions to our panelists. I can assure you our doctors will give you good advice. And now it is my pleasure to introduce to you my good friend and the moderator of today's webinar, Dr. James Bikeway. James has an extremely colorful personality, as you will see in just a bit. He has over 20 years experience in the media industry and is the associate professor at the Zayed University. When he is not teaching, he can be found online doing his podcast and various other radio and talk shows. And now over to you, James.
Sharad, thank you very much, and a warm welcome to everyone here for the Adam Vettel Q&A webinar, and of course to our esteemed doctors. I want to take just a second though to remind everyone and sort of introduce Adam Vettel, because this is an established brand name and a respected healthcare operator with its origins in Germany. Adam Vettel Hospital is located in Garhoud in Dubai, and it is a premier inpatient and outpatient medical facility specializing in orthopedics, specializing in physiotherapy and rehabilitation, sports, and regenerative medicine. The hospital provides general observation, inpatient surgical services, and outpatient care for adults, primarily catering to, as I've said, orthopedics, regenerative, and sports medicine. Adam Vettel Physiotherapy and Rehabilitation Center is in Nad Al Hammer, and this is a premier facility dealing, of course, with physiotherapy and sports medicine, and it offers a range of services, including treatment of acute pain, sports therapy, and post-surgery or injury rehabilitation. Today, we are joined by 4 of the very talented medical professionals from the Adam Vettel Healthcare Group. And these experienced doctors are going to be talking to us about medical issues, the medical issues that are on your mind, and they're going to be offering you an exceptional opportunity to ask your questions. So, who's joining us today? Very shortly, Dr. Aladdin Talat will be with us, and he is a consultant orthopedic surgeon who specializes in spinal issues. We have Dr. Tariq Assalam, who is a consultant rheumatologist who previously worked in the Center of Excellence in Musculoskeletal Disease. Dr. Ahmed Rashid, who is a consultant orthopedic surgeon who has a special interest in upper and lower extremity surgery and general trauma surgery. And finally, we have Dr. Tamer Mustafa, who is a cardiology specialist and who has a special interest in heart failure management. Between them, our medical panel has over 65 years of experience in dealing with a wide range of medical conditions and talking to you and me in words in a way that we can understand. They are going to be able to explain to us these complex medical issues, things that are on our mind, in a comprehensive way. And with that being said, why don't we jump right into our Q&A session? And let's jump in with Dr. Tariq Assalam, our first doctor on the panel. And we've got a great question for you, Dr. Tariq, and it's one that is on so many people's minds. What is arthritis? We hear the term a lot. A lot of us are really confused. Can you paint the picture for us?
Dr. Tariq, I think, has to unmute himself. Maybe while he fixes his audio, you could direct the question to.
Sure. You know what? I'm gonna direct our. Oh, Dr. Tariq is unmuted.
Yeah, he's okay. Yeah.
Good morning, all. Thank you, James, for asking me this great question. Arthritis is a very broad term. In general, it means just the joint pains, but there are various types of arthritis. And I would like to highlight only 2 main types of arthritis, which we very commonly encounter in our rheumatology clinics. The one type of arthritis is the one we call as old age arthritis, or it is also called as osteoarthritis. This type of arthritis usually happens after 40 years of age, and it involves our large joints, mainly knees and hips. And the main reason behind this arthritis is loss of cushion between the joints. This is very common type of arthritis we see in our clinics, and there are lots of risk factors towards this. And the main thing is that if this arthritis gets diagnosed early, we can take some measures to prevent the further disabilities. And the second type of arthritis, which is most common, and I would say, which requires aggressive management, is inflammatory type of arthritis. And the main inflammatory arthritis is the rheumatoid arthritis. And in this, we get swellings of the joints. And the swellings of the joints happen mainly due to antibodies, which are fighting against our joints. And to complicate this disease further, and that is why this requires urgent attention, is these antibodies can fight with other organs of the body. And that can actually result in damaging your kidneys, your lungs, and in some cases, it can also affect your blood vessels. So that is where we require a urgent reference to the rheumatologist for early diagnosis and for aggressive control of the disease. And the third type, which is also coming under the same umbrella, the inflammatory arthritis, is a crystal arthritis, which we very commonly call as gout. And this happens due to uric acid. So these are the main types of the arthritis, which we commonly see in our clinic.
Dr. Turk, thank you very much. Our next question goes to Dr. Ahmed. And the question that we have for you, sir, is you are an orthopedic surgeon. What are the most common types of complaints that come to you in orthopedics?
Yeah, thank you for a very nice question. So orthopedic surgeon, this is when part of medicine is interest is musculoskeletal systems. So most people, they have the pain, musculoskeletal pain. This is number one reason why people visit their doctor each year. So pain in musculoskeletal. What does it mean musculoskeletal? This is bone, this is ligaments, this is joint. This is the whole system who's building the body. So pain. This is what
pain. We're going to come back to pain because that is a huge topic.
I want to clarify something. So people they understand that orthopedic who is when we have a broken the bone. So it is not only broken the bone. We are recover the fractures and the joint, ligaments, every musculoskeletal problems. Who is doing the pain? So we are recovery. We are losing the pain and safety.
So really quickly, when we think orthopedics, in my mind, I instantly think if I'm seeing an orthopedic surgeon, the surgeon part comes into what I'm thinking about, but really you deal more than just with surgery. As you said, you're dealing with the pain issues that people have and how we can work through those as they relate to your muscular skeletal structure.
Yes, exactly. So you are the orthopedic is not only surgeons. Orthopedic surgeon we have interested so non-surgical and surgical, and it's important for us is non-surgical. So not everybody we can going to do the surgical. So we have non-surgical. So pain medication, we have rehabilitation, we have injection. So last list for the treatment for this difficult pain or severe pain, we have to do the surgery.
Dr. Ahmed, thank you very much. Dr. Tamer, we have a question for you. What health conditions increase the risk of heart disease?
First of all, I'm very happy to share in this interactive conversation live. And it's a good chance to highlight or spot some problems that can lead or endanger our health of the heart or our heart condition. Needless to say that cardiovascular diseases are the leading cause of death worldwide for all the people. And this is mentioned by WHO registrations and the official sites. So cardiovascular disease comes as the leading cause of death worldwide, beside cancers, infections, and road traffic accidents. So it's very important if we can try to limit or at least to slow down the progression of our cardiovascular diseases. Now we have some factors that might increase the incidence, the progression, the severity of the cardiovascular diseases. Those factors are called risk factors. From its name, we can come to know that it endangers our life. It puts bad insults on the health of the heart. Those factors are divided actually in two parts: controllable factors and uncontrollable factors. And again, from the name, controllable factors, the factors which we can control it, we can master it. And out of those factors are our body weight, our hypertension, our dyslipidemia, our status of diabetes, and our food habits, our lifestyle. Those are called controllable factors. Like we can control it, we can reduce its incidence, we can modify it. And another group of factors which are called uncontrollable factors, like I'm born from a family with a positive history of ischemic heart disease. I'm born in a family with a positive history of hypertension. I'm born in a family with cardiac muscle disease. So those factors, I cannot control it, but I can reduce its impact. Again, whether the patient is male or female, or the person is male or female, because some cardiovascular diseases are more in females and some others are more in males. And my race and my ethnicity, because some cardiovascular diseases are common in special groups or races, and those factors you cannot prevent it, but again you can control it. You can control its combination with other controllable factors. I mean, when you have one risk factor, it's less dangerous than when you have two risk factors or three risk factors or four risk factors. So at least you can reduce the number of risk factors you have in your body. I need to say also that risk factors, it's not only to prevent the cardiovascular disease. Even those who are infected or affected by cardiovascular disease, they can improve the prognosis of their disease by controlling this risk factor. And actually, this is the responsibility of the person himself and the treating doctor or the one who is supervising his health. So I have to find out the risk factors in my body and try to modify it and to find out the best protocol to improve these risk factors in my body, to reach out to my target, which is a healthy life.
Excellent. Thank you very much for that very comprehensive answer. And there's a lot that we want to come back to talk to, so don't move. Dr. Aladdin Talat is here with us, also a consultant orthopedic surgeon. And we want to fire our first question to you, Dr. Aladdin, and that is, why is lower back pain so common amongst pretty much everyone?
Hello, everybody. Lower back pain is very common. You can say in the lifetime incidence of back pain for anybody is 80%, like the whole population nearly. Back pain is very common now because the human body is designed to stand and walk. And the modern life obligates us to sit in the office at least 8 hours a day. This position unfavorable to the intervertebral disc and surrounding ligament. So with time, it puts stress, and at certain point, the disc in the intervertebral space will fail and end up by compressing some vital structure, or by its failure itself, it causes pain due to instability. Instability means abnormal movement and the lower back.
Excellent. Thank you very much. And you're opening up some great questions here. So again, we're going to come back to this topic as well. I've got another question for Dr. Tariq Assalam, and that question is, what are the risks predisposing us to arthritis? Sharad, we've got to unmute Dr. Tariq.
Yeah, he has to unmute.
There we go.
Yeah.
Can you hear me now?
Yes.
Yes, we can hear you, Dr. Tariq. So the question was simply, what are some of the risks that predispose us to arthritis? And I say this because, and I've got a little bit of a personal side here, as someone who is, in his 50s, and I keep thinking about my grandparents who had a variety of different sorts of arthritis, and I keep thinking, I don't want to be that. So what can we do? what are some of our options when we start looking at arthritis and some of the risks that predispose us to it?
Well, it is a very good question, and it is not only you. We come across this question very commonly in our clinics, that whoever visits our clinic, they just want their family members to be safe as well. So they pose the same question to us. So actually, there are some factors which are modifiable, but there are some things which do not have control over it. So I will go through this in the same manner I went, for answering my previous question. I will discuss the risk associated with osteoarthritis, as well as inflammatory arthritis, which is called as rheumatism. So let's start with the osteoarthritis. As well as osteoarthritis is concerned, we have seen that this type of arthritis is more commonly seen in elderly patients, and that the risk starts increasing from 40 years of age. And this is also seen commonly in women. And the major risk factor, which is also modifiable, is the obesity. That if you are having more than your ideal body weight, your risk of getting osteoarthritis is higher than the general population. And also, if you have any injury in the joint in the past, then your joint is more predisposed to get the osteoarthritis in your life. And by this osteoarthritis, I will explain again, I mean the wear and tear type of arthritis, which every one of us will get at some age. But the severity depends on to the involvement of the joints as well as the risk factors. Also, I would like to know that I would like to highlight that there are some conditions like rheumatoid arthritis or hypermobility, which is called as double jointedness. These underlying conditions can actually cause damage to the joints, and this joint damage can predispose us to develop this wear and tear type of arthritis. And as Dr. Aladdin has already explained very well, that the osteoarthritis in the spine, which is also called as spondylosis, is seen in those people who are using their spine and putting too much pressure on that, maybe sitting for a longer period of time, or maybe their job does not help. So this is a risk for osteoarthritis. And regarding the rheumatism, which is the main area I would like to focus, is the rheumatism, as I mentioned earlier on, is the inflammation of the joints. And the risk factors for rheumatoid arthritis are actually manifold, but most of them, they are not actually modifiable, because this disease happens with antibodies, and the antibody formation can happen in anyone due to just a programming error in our immune system. So we have seen that the rheumatoid arthritis happens mostly in the young age, and it can actually happen in any age. There is a family history usually associated with rheumatoid arthritis, like if someone in your family already have rheumatoid arthritis, your risk of getting rheumatoid arthritis is higher. It also happens more frequently in females. And in some studies, they did find the evidence that some gum infections, the bacteria which causing the gum infection can predispose you to the rheumatoid arthritis. Therefore, we always advise a dental hygiene. And during the course of the disease, if somebody has presence of antibodies, like rheumatoid factor, which is very common antibody we perform in case of rheumatoid arthritis, their chances of getting aggressive disease is higher. And in one very small study, they did look into the role of vitamin D in the rheumatoid arthritis, and they found out that those people who had rheumatoid arthritis, their levels of vitamin D were low. So they actually posed that maybe because of low vitamin D, you can get rheumatoid arthritis, but the study was very small. But based on this study, we always emphasize to our patients that they should take a good calcium and vitamin D in their diet. So these are only the known factors, and there are some genes which are associated, and as I mentioned that these are not the one we can actually modify.
Oh, we got more questions here. That's very interesting. And again, we're hearing from several of the doctors, from several of you on the panel here at the Adam Vettel Q&A webinar, that gender can play a role in things as well. So there's lots to be thinking about here. I want to send our next question over to Dr. Ahmed Rashid. And you, in your last answer, you were talking about the fact that what you're dealing with in orthopedics is not just the bones, but the structures that are affiliated with those bones or that are related with them. So why should, or how do you talk to a patient about opting for a surgical procedure versus not opting for that surgical procedure? What are the things that you need to consider in your practice?
So, okay, we come again to our webinar. Actually, so I told you, the more patients there understand this orthopedic, this is a surgeon, this is a broken bone, and we have to fix it. This is no. So this is coming about the question why he's coming to me. So we have doing a good diagnostic first. So from where, why this pain. So when we have a good diagnostic, so we have to taking just the treatment. Not only treatment, so I told you it's about the non-surgery and surgery, so conservative or operative. So we are going first thing from basic things. So pain medication, we have a very nice diagnostic, for example, about the joint. So patient is coming with joint pain, so we can, when we have a good diagnostic, this is not trauma. When it's trauma and broken on, it's very severe pain. So this is a surgery treatment. But what we are doing, we are treating with small things, with pain medication, with physical and rehabilitation treatment. When is no, so we're taking the third treatment. This is injection, for example. When we have no way, so we have last way have to treat the patient. This is the surgery. One thing is important I want to speak about, this is education and training the patients with our treatment. So for example, when you have doing the sport, football or something, so and he has pain, so how you are going to recover him to his sport? So we are giving him the education, and this is very important. Sometimes with physiotherapy, with conservative therapy, and after operation. So how long time he have to doing the sport and recovery to his work or his daily job. Yeah.
Excellent.
Can I speak little in Arabic language, because you have some things they speak only. Can I or no?
Sure, go ahead.
Yes, very good. So صباح الخير، أهلا وسهلا فيكم. عند دكتور أحمد راشد، أخصائي في طب العظام في مشفى آدم فيتال هوسبيتال. نحن اليوم في محاضرات حول الطب في المجال الاختصاص العظام. شرحنا في الوقت الحاضر انه نحن كاطباء العظام لسنا فقط جراحين، لا، نحن نعمل الدياغنوستيك اللي هو التشخيص انه ليش المريض بيجي لعندنا، اكيد في عنده الم. فاول شيء الاورثوبيديك هو يعني المريض اللي بيجي لعنده اكيد في عنده الم، فنحن بنعمل التشخيص للالم هذا على ضوء التشخيص، هل يا ترى محتاج الى جراحه ولا لا. في قدر الامكان نحن نساعد المريض الى الحاله قبل الاصابه، كان اصابه مزمنه يعني المرض الالم المزمن، او الاكود اللي هو هلا صارت الحاد نحن بنقولها يعني. فاذا كانت مثلا اصابه كسر لا جعل الله، فبقدر الامكان نحاول انه نتجنى العمليات، ولكن اذا كانت مضطره فنعمل العمليات. فاغلب الاحيان نحن ندخل بالكونسرفاتيف، المعالجه ليس فقط عن طريق الجراحه، لا، في عندنا المعالجه بالادويه، المعالجه بالابر، المعالجه بالعلاج الطبيعي والفيزيائي، اللي هي بتخلي المريض يعود الى حالته الطبيعيه قبل اصابه الحادث او الالم. هذا هو بالنسبه مهم بالنسبه للاطباء. طبعا المجال الاورثوبيدي مجال واسع، في عندنا كثير اختصاصات موجوده في الاورثوبيدي، اطباء العظام، في حتى للاطفال، في حتى مختصين لجراحه اليد، المختصين فقط بامراض اليد وجراحتها، في مختصين بسرطانات العظام، في مختصين بجراحه الكتف والني اللي هي العربي مش كويسه، بس هي مثلا عظم المدور او مفصل المدور او الركبه، وكمان الاختصاص في جراحه العمود الفقري. اهلا وسهلا فيكم مره ثانيه، ونستنى الاسئله من المشاهدين الكرام. Thank you.
Dr. Ahmed, thank you. And I want to move on swiftly to Dr. Tamer Mustafa. And I want to come back to some of the issues that we need to be thinking about when we're thinking about heart disease, and really the role of that family history, the role of our genetics in how we think about and how we manage heart disease. Can you talk to us about that?
Yeah, definitely. First of all, I want to raise two questions which runs in the brain or in the mind of most of us. As a patient, as a doctors, as a human being, I am too young to have a heart attack. Can I face a heart attack if I'm less than 20 years old or 30 years old, or it's just the disease of elderly? No, unfortunately, heart attack can still happen in younger decades of age. Can happen to people of 30s and 35 and 25 and 40. So it's never too early to have the risk of getting heart attack. And it doesn't mean that because it's a chronic disease, it will happen only after the age of 50 or 60. So I shall early address and acknowledge the risk factors in my body and work closely with my doctor, trying to modify those risk factors to prevent it, to clear it. Then I can have a healthy lifestyle later on. As parents, fathers and mothers, we should grow up our children on a healthy lifestyle, on a healthy life habits. They should practice exercise. It's not the responsibility of myself. My responsibility comes to my kids, to the people, to my beloved children. I should give them the right health data. I should grow them on practicing exercise. I should watch their food and my food. I should tell them clearly that smoking is a very bad habit that can destroy your heart and vessels and can give you a very miserable life. We should all together as a family member seek and check regularly our blood pressure, our sugar status, our lipid profile, our electrolytes. We should have regular visits to our doctors. We should enroll ourselves in campaigns of anti-smoking and blood pressure control and getting healthy lifespans, because it's a workshop which we should be involved in to get our best and better lifestyle. So now you asked me about my lifestyle, my bad habits which can endanger my heart. Yes, there are a lot, as we said earlier. We have controllable risk factors and uncontrollable. We can combine all those factors in major things now. If I'm smoking since being young, I'll be in high risk for cardiovascular disease, because we all know that cigarettes are a leading cause of cardiovascular disease, which can cause death of me and the people who are smoking via its contents of nicotine, carbon monoxide, and hydrocarbons, and tar. It can cause cardiovascular disease, increase the workload of the heart, increase the heart rate, increase the blood pressure. It can cause lung diseases, including cancers of the lung and chronic obstructive airway diseases, and increase the chance for the person to get infections and destroy his immunity. So it has its impacts on the health of the heart, of the lungs, of the brain, of the blood vessels. As I said, it's a leading cause of cancers. So smoking is a very bad habit. And let me say that some people who are smokers, they have the gene of cardiovascular disease. So they can get the cardiovascular disease 4 times more than the people who are not having this gene, although they are smoking. And we don't know we are carrying this gene or not. So finally, it's not a simple thing. It's a bit complicated. So smoking should be completely stopped, or you should quit. If you are not able, there are a lot of people who can give you a hand, who can help you. As I said, you can enroll yourself in a campaigns of end-smoking. You should have regular check for the doctor to check your lipids. Lipid is a fatty material circulating in the blood, and it ends up with settling in the intima of the blood vessels, causing what's called plaques. Plaques reduce the blood flow to the target organs and causing strokes in the brain, in the heart, in the kidney, in the muscles. So you should check your lipids, you should control it, and you have useful lipids in the body which takes these plaques and fats from the vessels and reach it to the liver to get rid of it, and another type which is harmful. which collects all the fat of your body and puts it inside your vessels, causing its block. So you should check your useful and your harmful types of lipids. Not only this, you should check your blood pressure regularly, because as we know, the blood hypertension is a leading cause of cardiovascular disease. It can cause a lot of complications in the body, like heart failure, like arrhythmias, like acute myocardial infarction, which is simply the heart attack. After checking your and controlling your hypertension, you should check also your sugar. Sugar is needed. Sugar is glucose, is the source of energy to our body. And all the cells, they utilize and use this sugar to build up its energy. But to get the maximum benefit from glucose, you should have good insulin production and good utilization of this insulin, which is secreted. And in patients with diabetes mellitus, unfortunately, they don't have this mechanism. So we should check, we should consult our doctor, we should control our sugar. Now, our part also, if we stop smoking, but we are using alcohol, we should moderize. We should use wisely the alcohol if we are using it. Not more than 1 or twice usage per day. More than this will be harmful. And the heart is one of the organs which is mostly affected by increased alcohol intake. It can cause arrhythmias or irregular heartbeats. Alcohol itself can cause heart failure, a condition in which the function of the heart is becoming less or deteriorating. It can cause acute myocardial infarction or heart attacks. So we don't advise people who are using alcohol to increase their usage. And those who are not using from the start, we don't advise them to start using alcohol. So alcohol also should be considered. Our diet is very important. A healthy diet should be undergone by all of us. Choose your nutrition, rich food, nutritious food, which contains vitamins, minerals, fibers, and other nutrients with less calories. And try to choose good sources of those things, like eating fish, seafood, white meat, nuts, cereals, grains, whole grains. This is very important. Try to avoid bad sources of oils.
Dr. Tamer, I'm gonna cut you off for a second. We're gonna come back to all of these pieces that we want to take a look at and go through that whole process of when we should be getting checked, how often we should do that, and at what stages we need to start considering all of these things. But those are really, really valuable pieces of advice. Thank you very much. I want to get another question into Dr. Aladdin, and we've got a question also. So I want to sort of put a double question to you, Dr. Aladdin, and it's about pain, but it's also a question that's come to us from our audience. And Rohan has got a question that follows along on the common back pain that you were discussing. And he's talking about that he sits for long hours working from home, suffers from the chronic back pain that you were talking about. So what do you, wants to get a little bit more hands-on, what do you recommend as far as what we need to do through our day? I mean, we're all sitting here on Zoom. I'm looking at the screen of us. We're all sitting down. We're all potential victims, including yourself, of lower back pain. So what can we do? But I want to tack on a second question to that, because the second part that many people are complaining about today is not just their lower back pain, but is neck pain from constantly looking down at their computers. So how might we start addressing some of that? Dr. Aladdin.
Hello, nice question. Because the most common reason for disability from long sitting hours is the desk degenerative changes, which means simply that the desk is not functioning well. The same applies to the neck, because the neck contains at the cervical region about 5 discs, which are ready to suffer the same way like the discs in the lower back. If we sit bending forward, that put enormous stress on the disc of the lower lumbar region, and with time, we will have a disc problem. If we are applying this principle to the cervical region, which simply is the neck, and if we all, most of time, looking downward, as you have mentioned, or looking to one side like that, for someone working as IT and fixing to his head to one side most of the hours. These two positions are jeopardizing the health of the desk. Why? Because when you look to one side, half of the fibers that supports the desk is not working, is relaxing. So the whole weight that should be carried by the desk are only half of the fiber recruited to carry. So the other half will fail with time. The same happens when we look downward, plus the force on the desk amplified by about maybe 2.5 to 3 times. In the lower back, when we bend forward, sitting for hours, the load amplified maybe up to 10 times. So this is on the contrary of you sitting backward like that, like you are reclining the chair up to maybe 45 degrees. In that case, the stress on the desk will be minimal and it will be very safe to sit for long hours. So to summarize, if you want to sit in the desk for long hours, you should sit your back supported from top to bottom and the back of the chairs reclined backward, this way, 45 degrees. And it's much better to work and you have armrest for the chair because carry part of the weight on the shoulder. This position will be very safe for your back. For your neck, what to do? We should put, like I'm putting now, my monitor just at the same level of my eye, that I don't have to look downwards that way. And at the same time, I shouldn't put it to one side because this is, as I said, will make the desk in a very unfavorable position and weak to carry its normal weight. That's the golden advice. It's better as well to put has like a cushion at the lower back. This is should be done by all normal people and with more attention if someone's suffering back pain. Coming to this, I'll get stopped at this point, waiting for the next question.
Okay, I'm going to want to come back to the cushion talk because I've seen cushions, and we'll come back to it in our next round, but I've seen people who put cushions behind their back, and I've seen people who are sitting on cushions, and I've heard both good and not, people saying it doesn't really do anything and others saying it does a whole bunch of stuff. So I'd love to get your take on that. We'll come back to that in just a second. Dr. Tariq Assalam, I want to ask you a question about we want to talk a little bit about diet and arthritis, and this is interesting because we're hearing diet in heart, we're hearing diet in arthritis, we're hearing a lot of facts that when it comes to our health and our well-being, diet is really important. But we've got a question that I want to tack on, Dr. Tariq, and it has to do with pain management. And the question is actually not about arthritis, but I think you might be the man to answer this question. And it comes from, again, one of our viewers, and her name is Susan. And so I'm going to give you two questions here. The first one is about diet, and the second one is about using our over-the-counter pain medications that we might have for headaches or for our joints, etc. And Susan wants to know, she takes Panadol for pain management, and she wants to know, is it possible to become addicted to those kinds of over-the-counter drugs, and should we be worried if we're using these kinds of medications for pain management? So a diet question with arthritis and over-the-counter medications to manage pain.
Thank you very much for posing these questions to me. First of all, I think I would like to reply to Suzanne. She is asking about the Panadol. So I would like to, highlight one thing, that if you are using the painkillers on a regular basis and we do not know the underlying problem, what is happening, I would suggest a referral to the rheumatologist. Rheumatologists are the one who are the arthritis doctors. They are the one who can look into the joints and see what is the problem. As I mentioned early on, the early diagnosis can actually prevent us from having long-term complications and disabilities which can affect our functional capacity. So first thing is that, what is the diagnosis? Why we are taking these Panadol on a regular basis? For example, if this has already been looked at, then Panadol is the safest medications among all the painkillers, which has no addiction potential. But once again, if you require Panadol every day, then we need to look into that whether this joint disease we can cure with some other kind of medications or not, so that we don't have to take the painkillers every day. We are in rheumatology now. We are the arthritis doctors. All the joint pain, spine pain comes to us. We are working towards this approach now. The patient should not be taking any long-term medications like painkillers or maybe any kind of steroids. If we require any of these on a regular basis, then you should be seen by the rheumatologist as soon as possible to make the diagnosis and start the appropriate medications. So I think that answers Suzanne's question well, what she needs to know. And now regarding your question, which is $1 million question, I would say, I come across this question from all of my patients, that is there any diet which can actually prevent us from arthritis? And there is another question that whether it's a diet which can help during the arthritis. So let's answer this question in these two ways. One is that whether there is a diet which can prevent the arthritis. Like I already mentioned, that osteoarthritis, which is an old age arthritis or the wear and tear type of arthritis, that is more commonly seen in those people who have obesity. So eating healthy is very important so that we can maintain our ideal body weight, and that can actually prevent us from having osteoarthritis, or maybe slow down the progression of this degenerative disease. One thing, and secondly, that during the arthritis, this is a very important question. As we know, the joints are made up of the bones. So vitamin D and calcium is very important for the bone health. So our diet should contain sufficient amount of vitamin and D, which we can get from like salmon, mackerel, lots of other things. And also our breakfast cereals nowadays, they are actually fortified with vitamin D and calcium. Another very important point, those patients who suffer from inflammatory arthritis like rheumatoid or any other kind of inflammatory arthritis, this ongoing inflammation of the bones and joints, which actually deprive your bones of the calcium. So that means the bone is losing the density, and the bone is becoming more brittle, and it can fracture very easily. So that is where the role comes for regular vitamin D and calcium supplements for those patients who are having a rheumatoid arthritis or any other kind of inflammatory arthritis, especially those who are taking the steroids as well, because these steroids also weaken your bones. And obviously, there had been a lot of studies on an anti-inflammatory diet. If somebody has scrolled on the internet, they might find that we all know that the diet has, most of the ingredients in the diet has various functions in the body. So there are some ingredients which are supposed to have this, anti-inflammatory properties, and including those in your diet can actually help. And I can give you some examples like fresh vegetables, fruits, nuts, salmon, berries, and in the spices, turmeric, that has been proven to have some anti-inflammatory properties, and the green tea helps as well. I think that that will explain your question as well, that what is the role of diet in the arthritis. And if you have anything more you want to know, please come back to me.
We're definitely going to come back to you. There's a lot more questions lined up here, but we're going to move on to Dr. Ahmed Rashid. And really quickly, Dr. Ahmed, one of the words that keeps coming up when we talk about orthopedics is sports medicine. And this is a huge area. And actually, Adam Vettel Health Group at the Physiotherapy and Rehabilitation Center in Nad Al Hamar is very much into sports therapy and sports medicine. What is, when we say the word sports medicine, what are we talking about?
Thank you for this question. It's very important, and the sport medicine is for young people all world. So, sport medicine is a part of orthopedic who is interested for injury in the ligaments and joint and muscles again with sport. So we are taking some example like ACL injury or some joint on the luxation. So what we are doing the conservative therapy, we are doing conservative or orthopedic operative therapy. So here is a role for physiotherapy and rehabilitation and recovery. This is the 3 words. So when he's coming with injury, for example, and he did not know the operation after the diagnostic exactly. So what we are doing, we are sending the person, referral person to our center for Dr. Adam Reha and Physiotherapy, and they are recover the patients. And this is important, how long time, what's the injury, or after operation. So in sport, so when his ligament is injury, or the cartilage, for example, or muscles cut. So after operation, it is very important how he's going to doing the conservative now, conservative or after operative, and this is a rehabilitation medicine. So he's giving the time, and this time he have to recover before the accident or the injury. Yes.
Okay.
In Arabic language or no? Again.
No, I think we're fine. I think we're fine. But I get what you're saying, because I mean, when I'm thinking of all of the times when people are out, doing some activity and they get that hamstring injury or a ligament injury, and then they've got to go in and they go to see the doctor, but they haven't really recovered enough to now go sort out what the other things are. Sports medicine makes a lot more sense. Excellent answer. Thank you very much. I want to move on to Dr. Tamer Mustafa. And I want to come back to you in your last question. You answered so many things, and you posed a couple more questions for us. So I want to sort of give you a sense of where I see this going. And so you were talking about the risk factors, and you were talking about food, and you were talking about things like smoking and alcohol and other behaviors that can have a huge impact on our cardio health. And so I wanted to come back to something that you were talking about, and you were talking about the good lipids and bad lipids in our blood. And so what I want to ask you about is how often and at what age should it, and again, this is a wide open question, so it gender fits into it, age fits into it, ethnicity, but generally speaking, how often at what age should we come in for a comprehensive cardiac investigation, sort of come in for our checkup? How often should we do that?
Okay, again, I want to address that. As I said, there is nobody is immune against cardiovascular diseases. Cardiovascular disease is a risky thing which can happen at any time, all of a sudden, or on a chronic basis. So we should be all aware about this. So we should start our plan for prevention and minimizing the effect of cardiovascular disease so early, as I said, in ourselves and in our kids. So we should check and be aware about those things in our kids, trying to implement those lines for our kids also and for our whole family. We have what's called the golden disease for cardiovascular issues in each age. For example, the young ages, they are liable more for congenital heart diseases. So we should be aware about the signs of congenital heart diseases in our kids. If they are getting blue, if they are losing consciousness, if they are breathless when they are practicing exercise, we should be aware about this. We should check them very frequently and early, even since birth through all their life. Again, in adolescence, they have the golden diseases for this age, like valvular heart diseases, rheumatic heart diseases. It appears in the adolescents and in the teenagers. So if we have also children and sons or daughters who are in this age or our surroundings, we should take them and check them frequently, especially if they are coming from a family with a positive cardiovascular disease. Again, in the elderly, they have their golden diseases like the ischemic heart diseases, atherosclerotic heart diseases, strokes. So each age, it has its more frequency of cardiovascular diseases. Not only this, so it depends, it's a dilemma, depends on the liability of cardiovascular disease and myself and my family. If I'm coming from a history of a family with history of cardiovascular disease, if I'm carrying one or more of the risk factors which we mentioned before, if I'm leading a very bad lifestyle in my life, I should stop and change it directly. If I'm not visiting my doctor, so how frequent you are asking me to visit my doctor, it depends on all those factors. If I'm not having any risk factor, I'm doing my physical and regular exercise at regular basis, which is at least 150 minutes per week. And based on the studies which showed that if I'm practicing my exercise regularly and at fixed timings, or at least 150 minutes per week, I'll have 30% less chance to develop cardiovascular illness in myself and my surroundings. So I should weigh between my lifestyle and my regular visits to my health provider. Depends on if I'm sick or not, I'm having a family history or not, I'm leading a good lifestyle or not. I'm aware about my risk factors, addressing it, acknowledging it, and trying to modify it or not. Again, I want to stress on that cardiovascular disease is a very risky thing. It happens at any time. There is no time. It's not so early or too late to face this disease. It's not a shame to go to my doctor whenever I feel any minor or major abnormal finding in myself. So it's better to treat it early rather than not to get treatment for it. So it's a campaign, it's a workshop which is done between myself and my doctor. And we put our plan. And you can find in all the strategies of treatment of all cardiovascular illnesses now that the first line of treatment is lifestyle modification. So this is my job, to improve my lifestyle modification. And the doctor's job is to find out, to know from the patient about his risk factors and try to put for him the plan and to do his job of giving him the new strategies of improving these risk factors and treating his disease. And we have new modalities of management now and investigations. We have a lot of modalities of investigation and new drugs and new interventions which help the patient and the person to get early recovery.
Sounds to me like what I'm hearing. Number one is you need to be listening to your body, and you need to be talking to your doctor, and ultimately you need to be honest. If I'm coming to see Dr. Tamer, it's, I'm hitting the shisha too much and this, I need to tell you that and you're not judgmental, but you're going to direct me on, hey, this is a dangerous lifestyle and this could lead to a cardiac issues. And I think, honesty and talking to your doctor sounds to me like it's a must-do from as early as possible, and sharing those details. As you said, family history has come up again and again and again as you've been talking, that we need to be communicating and sharing. Excellent. Thank you very much. I want to move on to Dr. Aladdin Talat, and I've got a great question that we hear, and I hear it quite a bit from folks, and they talk about, I've heard more than a few people talking about this idea that they've been doing exercise, they've been at the gym, they've got an injury, and in some cases I've heard people talk about, I've got a compressed disc. What does that mean? And if indeed someone does have a disc compression, how do you fix it? What do you do today?
Yeah, this is a question I'd like to answer the most, because today, if someone has a disc in the lumbar region, which is the most common disturbing the quality of life, usually we go through the normal sequence of management. We try conservative management in terms of rest for 3 days, then rehabilitation, physiotherapy, in direction of to strengthen some muscles and relieve pain. And that's everybody does. And usually this is successful in about 70% of cases. But the problem happens in the other 30% that this conservative management fails, and they will keep complaining, and their quality of life become very bad. If somebody complaining of severe back pain, he cannot enjoy anything in life. Even he cannot go to work happily, and he will be grumpy the whole day. So that's why the new recent modality in many invasive technique in treating the lumbar disc have solved all these dilemmas. In the past, everybody who will go to back surgery, he thinks that he may ruin his life forever, and he may lose his ability to move. This is all like phobias from the surgeries in the back. But all this has been overcome by the mini invasive techniques, which is actually like one-day surgery, and the patient get out of the hospital walking with pain-free, something like magic, which is simply we use the laser technique and shrinking the disc. For the audience to know, lumbar disc issue, simply it is a protrusion of the disc. When the disc protrude, make compression on the adjacent nerve, which is the only reason for the patient to suffer. So if we can reverse this protrusion and relieve the pressure of the nerve without making open surgery, that's a magic. And that's what the laser does. We introduce the laser beam through very tiny channel, which are about 2 millimeters, through a special trajectory, and it reaches the center of the disc. And through this channel, we send the fibers that carry the laser beam, and we heat part of the center of the disc, evaporating some of it. So we will end up by shrinking of the disc, and this protrusion disappear. The success rate of this procedure is very comparable to the most successful open surgery and even more. Usually we can attain in most of cases like 90% recovery of this. And the best part of that, you have no back incision, and if you didn't recover, at least you didn't lose anything. If you are the unlucky 10% that will not recover from that, you will not lose anything, and still the open surgery is a valid option. But we are talking about 20-minute procedure that can replace an open surgery, which was a phobia for most of patients, even for myself. So that's nobody should be fearful of making this procedure to resolve his pain. And the nice thing about that, when the patient do this, the next day he can resume his life in a normal way, even go to work, to do whatever he needs. It will be just giving him a precaution, like don't lift heavy things for the next 3 weeks. That's it.
Excellent. Thank you very much for that answer. And we have a question for Dr. Ahmed. And the question comes back to talking about, again, when we talk about sports medicine and ligaments, actually. And the question is talking about when we talk about ligaments and we talk about our bones, what constitutes conservative management versus sort of operative management in this scenario?
Okay, thank you very much. I cannot hear you good, but I understand this is you are asking about the injury of conservative or operative, about ACL or ligament. Yeah. Okay, so now we have two different pain diseases in the ligament. So we have the inflammation, or we have injury, sprain or cut. And this is we have to do the diagnostic. You know, the diagnostic is with clinical examination and the radiology examination. And we are going to the first is about conservative therapy. So in conservative therapy, when it's not injury, so we can, with inflammation, so we can give him the anti-inflammation medication as tablets or injection. But we have new things. This is a new area, is PRP, so degenerative medicine, so blood-rich plasma, and we are doing the treatment as a conservative. When we are going to operative, so this is recover the ligament with stitching or with a new, like ACL reconstruction, more ligament we can do the construction, but in the new way. Now we have in our hospital, we are doing the arthroscopic way, minimal invasive way, and after we are going to the recovery. Again, this is very important. we are still the first is to our research, physical. This is okay now? Yeah. The Rehabilitation and Physical Center in Homer, Center Dr. Adam, and we are doing collaboration with not only treatment with physical therapy, education and training and with education. So we are giving the patients exactly the information how he is going to help us to recover his the ligaments pain or injury. So, for example, not carries heavy things, not standing at a long time, not sitting, not running exactly after the operation. So we are gives a exactly program to our patients to recovery his musculoskeletal, ligament, and ligaments.
Dr. Emmett, thank you very much. You know what, we have come to the end of our Adam Vettel Q&A webinar. Before we do anything, I absolutely want to thank Dr. Aladdin Talat, Dr. Tarek Assalam, Dr. Ahmed Rashid, and Dr. Tamar Mustafa. I think all four of you deserve a huge round of applause for taking these questions, comprehensive answers, taking questions from our audience, and wonderful, lots more to come. And obviously we know now if we need to have a conversation, as all of you have said, we as patients need to do our part as well, have that honest conversation with our doctors so that we can find that solution, so that we can work for our better health. And it's a team effort, and Adam Vettel has a great team to help us with that, the Adam Vettel Healthcare Group. So thank you all very much for spending that time with us and helping answer these questions. If you, and of course, there are so many of you who joined us, and some of you had to come and you had to go. If you want to find out more, you're going to want to listen to this again. The podcast, the webinar will be available at www.onlywebinars.com, and also at the Adam Vettel Healthcare Group. We'll make that available for us as well. What a pleasure! What a pleasure! And as we said, Adam Vettel is origins in Germany. Great group that's operating both in Garhud and in Nadalhammer with a specialist physiotherapy and rehabilitation center. I'm going to fire back to Mr. Sharad to wrap us up, but thank you all for taking the time to be with us.
Yes, I just want to thank our audience today, our panelists, all the four doctors. We are wiser and more educated. Thank you so much. And thank you, James, for moderating this session. We look forward to having everybody back again soon when we do another webinar to take in more questions from the audience. So thank you, and we sign off now. Bye-bye.